Good afternoon. I'm Vince Kinsler, the President and Executive Director of the Parkinsons Association of Greater Daytona Beach, and I'd like to welcome you all to our third in our initial series of 3 interactive webinars dubbed You, Me, and PD. Today's program is titled Ending Parkinson's Disease, the Parkinson's PACT and Emerging Treatments. We are living and experiencing a very unusual time. There's no doubt this represents a huge shift on how we will now be called upon to live our lives and ultimately how we interact with each other, including education. It is our belief that webinars like these are the future of enabling people to congregate in a safe and interactive environment that may otherwise have been presented in a more traditional type of setting. As the fastest growing neurological disorder in the world today, it has been suggested that Parkinson's has reached pandemic levels, with numbers of people diagnosed jumping from 3 million to 6 million in just the past 25 years and likely to double again by 2040. In his presentation today, Dr. Okun will in part discuss PACT, a bold Parkinson's disease initiative recently proposed in the newly published book, Ending Parkinson's Disease, which Dr. Okun co-authored. PACT is an acronym for Prevention, Advocacy, Care, and Treatment. A world-renowned expert in Parkinson's disease, our guest today is the medical director for the Parkinson Foundation. He's an Adelaide Lackner professor and chair of neurology and executive director at the Norman Fixel Institute for Neurological Diseases. Please join me in welcoming Dr. Michael Okun.
Great. Well, thank you all. I really appreciate, Vince, your kind introduction, Elaine and everybody from the Daytona Parkinson Support Group, and thank you for having me. I have been to your group before, as we talked about. I remember being in the large auditorium that had a Booker T. Washington exhibit. And Booker T. Washington is one of my favorite people that I like to read about in history, and so I enjoyed my last trip to Daytona. And I'm sorry that can't do it in person, but I'm really happy to see that we have 42 participants online, and we'll try to have a little bit of fun today with this, as much fun as we can have in the middle of this, surreal and somewhat upside down life that we all now live. So with that, I'm going to talk today a bit about Parkinson's disease and going to cover a few areas. And as was mentioned by Vince and Elaine, there's a new book that just came out last month, and this is the book here, and I can't really see it on the camera here, but I can get it. But anyway, it's Parkinson, Ending Parkinson Disease. It's available on Amazon. All the proceeds go to charity. So we, all 4 authors, Ray Dorsey from the University of Rochester, Todd Scherer, who's the CEO of the Michael J. Fox Foundation, myself, and Bastian Bloem from Nijmegen in the Netherlands, we've all pledged all the proceeds out. And so, if you do end up buying it, leave us a review on Amazon, and we're hoping to get the word out about the PACT. And I'd like to just start by reading you a small excerpt from the book. And because we're in the middle of COVID, this is one of my favorite excerpts that I've read a few times, but I'll share it with you. And this is from page 41, and it's about a new kind of pandemic. And it starts by saying epidemiology is the study of what comes upon groups of people, according to the late population health expert, Dr. Abel Amram. And for most of human history, what has come upon people are famines, infectious diseases, sometimes in the form of a pandemic. As opposed to epidemics, which are limited to given communities, pandemics cover large geographical areas. The Black Death killed up to 200 million people throughout Europe and Asia in the 14th century. The influenza pandemic of 1918 killed between 50 million and 100 million people worldwide and led to an unprecedented drop in global life expectancy. And so when we start looking at those numbers of knowing what influenza did in 1918, 50 to 100 million people were into the range of people that were killed during the Vietnam War, and now we're seeing this again with Corona. So it's sort of a history replaying itself. Thanks to public health advances, infectious diseases are no longer the leading cause of death and disability. The new leader of the pack is chronic conditions. In his landmark 1971 paper on population change, Amram called our current era the age of degenerative and of man-made diseases. Among these, cancer, diabetes, heart disease, and Parkinson's. This transition has led some to expand the definition of a pandemic to include diseases that are not infectious. The new carriers or vectors of these diseases are not bacteria or viruses, but urbanization, population aging, globalization, and the widespread availability of unhealthy products. Parkinson's disease satisfies many of the criteria of a pandemic. The disease is found everywhere in the world, in almost every region. The rate of Parkinson is increasing. And in addition, as with infectious pandemics, Parkinson's disease appears to be spreading and growing as industrialization expands. So that's just an excerpt about pandemic. I think it's fitting for where we are in the world today. And, I just want to stress that the authors, we don't seek to really get into a controversy as to whether it's appropriate to use the word pandemic. It's been taken over by the World Health Organization for infectious causes, and we totally agree that it's very appropriate to use it in that way. But for those of you who are history buffs, the word has been around since at least the mid-1800s and in use, and the roots of it are actually Greek. Pan means all, and demos means people. And so Parkinson disease really does fit in terms of its global growth across all people, all cultures, men, women, and their rapidity. And so I think it's just fun to start with that. Now I'm going to go ahead and ask everybody to mute your microphones. And if you notice on the lower left-hand part of your Zoom screen, there should be a mute button. If you press mute, there'll be a line that goes through so we can stay quiet during this. And then on the bottom of the screen, there's also something that says chat. And as Vince mentioned, if you have a question during the presentation, please feel free to type it in and I'll try to get to all the questions. And if I don't, I'm happy to send back the answers to Elaine and Vince and they can share those with you. Okay, so I'm gonna go ahead and try to share this presentation up. Okay, so you should see a slide that says Ending Parkinson's Disease, Emerging Approaches and Therapies with just a little bit of background on me. I have no conflicts of interest in terms of industry conflicts of interest, so I don't receive any personal payment from any industry or devices or device companies. I'm supported by the National Institutes of Health. Tyler's Hope for Dystonia Cure supports our center. The Tourette Association of America supports our center, and Parkinson's Foundation. And so those are the main areas that I want to emphasize that support has come from me. Okay. And this is just a picture of the new Fixel Institute. It's a completely all under one roof, interdisciplinary clinical research facility. And you can see we have indoor and outdoor waiting, and the patients compete for the spots on the walls. And it's a really neat place to go for your rehab, your research, your clinical care. Then we also have a new building, a brand new freestanding neuromedicine hospital at the University of Florida. And as we cleared the hospital out, the neuro hospital, part of the neuro hospital became part of the area where we were helping to take care of the COVID patients. So when we talk about Parkinson's pandemic, we've already sort of covered a bit about that in the reading, but what we really wanted to do when we wrote the book was to advocate that we needed a prescription for action. And so we spent a lot of time studying other diseases and trying to understand what it takes to actually get in front of diseases and to affect a change. Okay, so let's talk about how big is the problem. And so when we think about Parkinson disease, think about it now as it has recently become the fastest growing neurological disorder, most rapidly growing neurological disorder. That should, give you a little bit of pause. And why should we care about that? Well, I think if you look very carefully at the numbers, about 1 in 15 people over a lifetime. Okay, that means if you were in a classroom when you were growing up, let's say you were lucky enough to have a class size of 30 or less, at least 2 of the people that you know in a lifetime are going to get Parkinson's disease. That's a remarkably high number of people. And so when we try to put it into perspective, I think that the numbers really do matter. And these are numbers that Ray Dorsey has spent a good deal of his career studying. And one of the projections that Ray put together, he's done this a couple of times, and this is the most recent projection that was used within the book, is the projection of what's going to happen to Parkinson's disease. So if you look at the world's most populous countries, if you look at people that are over the age of 50, we know there's a lot of other people, but if we just sort of scale things and we look at numbers between 2 and 3 million in 1990, to 2015, the numbers go up to 6.3 million. That is a doubling, okay? And then we look at it again from 2015 to 2040, going from 6.3 to 12.9. And these are not every country. These are the world's most populous countries. So this is a real problem that if we don't get in front of it, it has the potential to not only affect our quality of lives, impact our families, but also bankrupt systems like Medicare. Now, if we look at what is the greatest advance of the last 100 years, I think scientists would all argue on this, but I have always posited that it's the fact that we've doubled our lifespan. People live longer. And sometimes we forget that, and it's important. And population curves like this don't lie. I mean, they tell us the truth. People are living longer. So we know that age is a major factor in Parkinson's and in neurodegenerative disorders. But we also know when we look at the data that age alone is not accounting for all of the cases of Parkinson or for the rapid rise in Parkinson. So this is really something quite astonishing. Now, how many neurologists do we have per capita? And the summary of this is that if you look at any country, okay, and you look across the different countries, you can see the United States sits pretty compared to the others at 3.9 per capita. And if we look at this, we understand that access to neurologist care will reduce morbidity, mortality, and nursing home placement, as been shown by multiple studies, including the most recent study by Allison Willis, who is at the University of Pennsylvania, and she studies population health within the Parkinson's disease groups. So we need more Parkinson's specialists, but we are not training more Parkinson's specialists. And when we went back and we took a look, this was with a group from Harvard. We did a small study with Dan Tarsi and Ludi Shi many years ago. We know that the number of Parkinson's specialists that is being trained in the United States each year is woefully inadequate. And in fact, there's a match, a fellowship match. And so what happens is people do training in neurology for 4 years after medical school. So they do 4 years of medical school, a year of general medicine, and 3 years of neurology. So that's 8 years. And then they need to do another year or two and in Parkinson's specific care. And only 40 to 50 people every year do that specialty training. So there is a real vacuum in the number of specialists that we need. And the other thing, when we were researching in this book, we spent a long time trying to understand other diseases like polio and like HIV, but we also spent some time looking at what are the myths, what are the things that people believe about Parkinson that may not be true, and separating them from the facts. So one of the myths is it's all due to aging. We know that that's not true. And in fact, many of you, probably some of you that are listening to this talk, are aware that you are very young and have Parkinson, and people that come to my clinics often comment that they see people in the waiting rooms that are extremely young, sometimes in their teens or 20s. Another myth that we see is that it's not treatable. And it turns out there are lots of great treatments for this disease. And so this is something that is unfortunate. And when we give the diagnosis of Parkinson's disease, it is frequent that we do this in an inhumane way, and that we leave people wondering whether Parkinson's disease is actually a treatable disease. And we should not do that to people. The other thing is this idea that there's nothing to be done about Parkinson risk, and it's not true. As we have gleaned both from the research in this book, but also from many researchers internationally, we are learning things that we should begin to apply to try to reduce the risk of Parkinson's disease. So when we talk about pandemic, remember, it's a Greek term. Pan means all, demos means people, so all people. And so we talk about that. Even though Parkinson's disease is likely non-infectious, it does exhibit many common characteristics with other pandemics and other infectious diseases. Pandemics extend over large geographical areas. Pandemics tend to migrate, and the burden appears to be shifting in response to changes in both aging and in industrialization. And in the 1800s, there was a tremendous boost in worldwide industrialization. And we know that the growth of Parkinson's disease is beginning to take on an exponential growth curve. Sounds a lot like pandemic. So again, we don't want to weigh too much into this controversy, but we do know that no one is immune to the condition, and that it beats many of the characteristics, if not all of the characteristics, of what was classically termed a pandemic, but it's non-infectious. So hopefully I convinced you that we have a problem that you should care about, and that's why we wrote the book. And what's the next step for Parkinson's disease? So what should we be doing? Well, if you look at HIV and you look at polio and you look at breast cancer and you try to boil it down to how they've been successful, we came down with this idea that it's really a pact. Prevent is the P in PACT, advocate is the A in PACT, care is the C in PACT, and T is the development of new treatments. PACT, the PACT. And so when we're trying to get everybody to put hashtag Parkinson PACT and hashtag ending Parkinson's disease, we're really trying to get people to buy into this idea that we need to really subscribe much more aggressively to these 4 areas if we're going to dent Parkinson's disease. So just a word on prevention. When we think about preventing the disease, we got to think about, are there things in the environment that we might be able to modify? Exercise, and one of the questions that came in was about exercise even before this talk from your group here in the Daytona group. And this idea, could exercise or another therapy or another drug, could this be playing any role in prevention of Parkinson? We don't know. And this search for drugs. So could there be drugs or devices that are slowing down or preventing the onset of disease? So we don't know. We know the most in prevention about the environmental factors. We know quite a bit about pesticides. And it turns out that we need to ban specific pesticides. Because if you go to Las Vegas and you place a bet based upon the probability that you think something is going to win or lose. We know now collectively from multiple studies that we can develop these things statisticians call odds ratios. When the bet is a 1, it's a push, nobody wins. But as that number sails from 1 to 2 to 3 to 5 to 10 in odds ratios, we begin to believe, if we see this across multiple studies, that there is a relationship, an association between two things, and in this case, between pesticides and risk of Parkinson. And now we're beginning to see this across multiple studies, across multiple chemicals. So one of the things that we talk about a lot in the book is banning specific chemicals. And one that I'll just give you an example on is called Paraquat. If you go into your garage, you might find Paraquat. You might find other chemicals like rotenone. There are many chemicals that have high odds ratios or high associations with the later development of Parkinson's disease. In fact, I was walking the dog the other morning, and there was one of these trucks that sprays lawns going around the neighborhood, and the guy opened up the side of the truck, and I saw a bottle of Paraquat that looked exactly like this bottle, and I said, oh my God, we got to walk on the other side of the street. The pesticide with the strongest link to the disease has been banned already in 32 countries. But in the United States, Paraquat, its use has actually doubled in the past 10 years. And because of the relaxation of regulations in the Environmental Protection Agency over the last 3 to 4 years, these things are not getting the review that they should. And in fact, if you look here, look at what's happened with Paraquat. It should be completely banned. Look at the United States and look where we live. There's a heck of a lot of Paraquat coming in, a lot in the Midwest, the farming regions. But look, it's almost a doubling here, or it is more than a doubling, depending on how far back you look. It is really, really bad. And so we should be discussing these things. And Paraquat's not the only compound. I always ask the question, where do you live? And in writing the book, we came across a lot of information on Superfund sites. And Superfund sites are where we've seen spills of different pesticides and herbicides, and remember, side in Latin means killer, right? So these are things that are used in gardening and in lawn maintenance. And it turns out that many factories sometimes use these types of compounds. And one of these compounds is also called trichloroethylene, or a TCE, and that's used a lot in the dry cleaning industry or for degreasing. And there's a TCE Superfund site that's a few miles from Ray Dorsey's house in New York. And then when I looked at Superfund sites, I have one about 11 miles from my house in an area that I know very well that has dioxin, which is a part of the components of Agent Orange and has been also linked to Parkinson. And by the way, Agent Orange is called Agent Orange because of these orange barrels that it was stored in. And so when you see the pictures from Vietnam, those orange barrels are the reason that they refer to it as Agent Orange. And I like to say this is Agent Blue. It's blue barrels for TCE, and this goes all the way back. This is a 1932 letter to the Journal of the American Medical Association, commonly used in dry cleaning, although a number of dry cleaners, like the one that my wife and I use, have switched to carbon dioxide or to organic types of uses to protect the workers, but a high association with Parkinson. Now, I'll tell you, because I'm a Gator, I'm from the University of Florida, it really worries me that we have orange barrels and blue barrels because those are our school colors. So let's talk about the A. The A is for advocating. And when we think about that, we have to ask the question, what did we learn from these other diseases? People that have done it right, particularly polio and all of the efforts for polio and the efforts for HIV, immunodeficiency virus. And when I started my career, when you saw patients on the wards with immunodeficiency virus, you would categorically think of this as sort of, this is the end. This is going to be awful and terrible for these patients. And now it's been converted into a chronic livable condition. Polio has been eradicated in many countries around the world. And so polio had a great advocate, and maybe the best advocate you can have is when you have the President of the United States on your side. This is a picture of Franklin Delano Roosevelt, who is pictured here with the famous comedian Eddie Cantor. And they started the March of Dimes. And this is where people actually mailed in dimes to the White House, and they created this amazing advocacy effort that ended up yielding the vaccine for polio. And so this was galvanization, true galvanization. In the HIV world, there was lots of examples of really charismatic and aggressive movement at trying to change the system, okay? And so this is a picture of, in HIV, this is a picture of them putting a condom over one of the congressman's houses, and they're trying to send a message to him. In this case, it was Jesse Helms is deadlier than the virus, because he kept voting against them, and he never challenged them again on this. And they were able to move this forward. They even seized control of the FDA, and this was really amazing. In a sit-in, they've done quilts across the National Mall. But if we look at what we did, how did we do in Parkinson's disease? How are we doing? How would I grade our response? I would put us at an F minus, okay? And that's pretty aggressive for me to say that, but I think we've had kind of a disappointing response. The disease continues to grow unchecked, and we have not done everything that we can. We need to be more charismatic. We need to be more involved. We need to create a more serious advocacy effort. And so when we think of this, we've got to change what we're doing. Now, when we think about care, that's the C in PACT. There are a lot of different treatments for Parkinson. This is not meant to overwhelm you. It's way too busy of a slide, but just to show you, this was a paper by Melissa Armstrong and I in the one of the most recent issues of the Journal of the American Medical Association, JAMA. And we have medical treatments, we have behavioral treatments, and we have surgical treatments for Parkinson's disease. And so this myth that there aren't treatments is worrisome to us, and we need to really get the word out to people. We also need to develop better models of care and better ways to deliver health care. So this is the model at the University of Florida. This is the Service and Science Hub model. It's all under one roof. We do patient-specific care plans. Every patient becomes a potential research subject, and in tracking outcomes, we can better prepare both the patients who have the problems, but also we can use this to try to improve the treatments. So patient-clinician researcher relationships, we've learned, are bidirectional. It's not just patient-centric. We need to be centered around helping what is going to happen, not only to the patients, but to the care team, and making sure everybody's committed. So this is what we use. It was published in JAMA Neurology a number of years ago. There's a model in Canada with Mark Gutman. There's one in Israel with Nir Jalad-D. There's one with Bas Bloom in the Netherlands, NetPD. It's not to say that any one model is the correct model, but we've got to do a better way of delivering value-based care. The other thing that we talk about is getting the diagnosis right. And so this was from the first book in Parkinson's disease called Parkinson's Secrets, or Parkinson Treatment, 10 Secrets to a Happier Life. This is a quote from the novel Pretty. And they say, I look for a sign, where to go next. You never know when you'll get one. And even the most faithless among us are waiting to be proven wrong. And it turns out when Parkinson patients visit with their physicians and advanced practice providers and receive the diagnosis, people are getting it wrong, okay? And so this is a picture of, this way to a world without Alzheimer's disease. My apologies to my colleagues in that area of research and clinical care, but Parkinson is not Alzheimer's disease. And many patients believe when they get the diagnosis, they believe erroneously that it is Alzheimer's disease. There's nothing that can be done. And then it's sort of the end of the world, this diagnosis. And it really isn't. It's very much a beginning. There are many myths that need to be addressed, and we need to be more empathetic when we give the diagnosis and make sure people know what that C is and what sorts of care we have. The other thing we need to stress, this is a great quote by Joshua Harris, is the right thing at the wrong time is the wrong thing. I love that quote. And it's so important for Parkinson. When we talk about that C, we have to understand that timing is critical. This isn't a disease that you just take these medicines and you'll be fine. A lot of people need to take the medicines at very specific times in very specific ways. And as the disease changes, they need to adapt to this. So timing is critical to success in the key, in the C. The C for care, also we have to think about hospitalization. And we see this in COVID too. We're trying to keep people in their homes. This is a very dark quote by Jared Kintz. He says, I have a favorite cemetery I go to because it's really clean and the doctors and the nurses are all very nice. It sounds horrible, but we know through the Parkinson Foundation, and these are the Parkinson Aware and Care Hospitalization Kits that we designed after doing about a dozen or so studies of hospitalization and Parkinson disease. And these are kits that can keep you safe. They're free. You can get them through the 1-800-4PD-INFO hotline. We've given out over 100,000 of these. And we go back to the core principle of Florence Nightingale, that the very first requirement in a hospital is that it should do the sick no harm. But we know that when our Parkinson patients go to the hospital, there's a high chance of there being a problem. Now, how about the R? Okay, when we think about the PACT, we think about research, and we think about the T, which is treatment. And I always think about that aspect of, you never go talk to a Parkinson support group like the Daytona support group and don't come if you're going to not at least update people on what's new and what may be coming, because people are waiting. And one of my favorite pictures is a picture of the man standing on top of the world looking at his watch, because it matters for people. The time matters for people. And when we look at research, we are woefully underfunded. And we know this because for the book, we studied polio, we studied HIV, we studied other disease states. We told the stories of those disease states. And so when we look, HIV receives about $3 billion a year. 3B, 3 billion. With that $3 billion a year prevented thousands, if not millions, from ever developing HIV. And remember, I told you the story of when I was an intern, what it was like caring for patients with HIV in the hospital and what the difference is now. Parkinson's disease in 2019 was funded at $201 million a year through the National Institutes of Health, which is the largest funder of research in the world. 201 million a year versus 3 billion a year. We are more than 10 times behind where we need to be. So we're underfunded. And why should we fund? People say, well, you've got pills and surgical treatments, and this is a picture of yellow dye number 5 and the pill known as Sinemet, carbidopa levodopa, the most common dopamine replacement pill for Parkinson's disease. And dopamine replacement pills are still the best treatment for Parkinson's disease. However, this treatment is now over 50 years old, okay? So we really need to move the needle here, okay? We really need to move the needle. The treatment does not stop disease progression, and we're still searching for treatments that will stop disease progression and have as meaningful of an impact on the disease as dopamine pills have had. So if you look at NIH funding comparisons, I have circled here for you where Parkinson's disease is, and I think you can see arthritis, breast cancer, Alzheimer's, and diabetes are all kicking our butts, and you already know that HIV is. So if we're going to get there, we really need to fundamentally change the research expenditures. So what's on the horizon with research? And when we think about this, we have to think about targeting of specific genes. So we're going to move into a precision medicine type of situation where, even though in Parkinson's disease, only about 10 or 15% have a single gene that we know about, in some cases, we're going to be able to develop treatments by understanding what these genes do and how they affect the disease and how the disease manifests itself. And so this will be called precision medicine. So we're going to see more targeting of specific genes. We're going to see improvements on the next greatest innovation in Parkinson care after the dopamine pill was deep brain stimulation, or DBS, so DBS and neuromodulation. We're going to see many more approaches, I think, in that area. We're going to see development of different drugs and repurposing of drugs. And one example would be things like Humira and those arthritis drugs that work on an inflammatory particle called TNF alpha. And it seems like people who get this may have a lower risk of later developing Parkinson. Doesn't mean we should all take it, but we should definitely begin to understand these relationships. So if we think about drugs, we have to think about this idea, could we repurpose drugs? And so this is a quote from Franklin Delano Roosevelt: "One thing is sure, we have to do something. We have to do the best we know how at the moment. If it doesn't turn out right, we can modify it as we go along." And so these drugs, as isradipine, inosine, pioglitazone, have all been tried as potential disease-modifying drugs in Parkinson. I'm sad to say that none of them have stood up. We have recent data on all three, most recently isradipine and inosine. And then also, for those of us that have been around long enough, we know that drug screens often turn up anti-malarial drugs, which is true in Parkinson as well. And you saw the anti-malarial drug showed up in COVID recently. And so those of us in Parkinson's disease weren't so excited about that one because we've seen this come and go. But this idea of repurposing drugs that are already developed and already on the market is still a good one. We're going to see improvements in deep brain stimulation. And so the improvements that we'll see is not only in designs of leads and how we can push electricity into different areas and adapt it to do different things. We're also going to begin to draw off the signals that are in the brain. We're going to listen to the signals in the brain and in real time have the devices respond to those signals and try to change the way we're delivering the stimulation to treat specific symptoms, just like the precision medicine that we see in drug delivery. And this is one of the things that our laboratory does. Now, I thought it'd be fun to have a co-author of my presentation today. So this is one of your support group members, Steve Piper, and he's written a great poem about deep brain stimulation. So I love poetry. My first book was poetry called Lessons from the Bedside. So I'm going to read his poem here. DBS procedures are a leap in neuroscience, using technology rather than prescription reliance. But deciding where to start is not technology, but fruit stand art. Hands freshly washed with soap. Your head is then thumped like a ripe cantaloupe to find two spots to drill holes in your head through which wires will be carefully led to areas most likely to benefit perhaps from an electrical charge to aid the synapse. These procedures are required before a controller is inserted and wired. Going from neuron to effector cell, the controller replaces what dopamine did so well. But calibration is needed in most cases and when carrying current to designated places. How it works is easiest to explain. It's like a pacemaker, but for your brain. The quality of life will improve, so give it a try, but not so your memory. Now, where was I? So fantastic, Steve. Thank you for that. And I'll just finish by saying there are other new therapies that are on the horizon. There are many immunotherapies. You see this in cancer. We're seeing this now in Parkinson. Can we use the immune system or can we manipulate the inflammatory system as potential treatments? We in Foch said vaccines are the tugboats of preventative health, and we have several of these in development, and we just don't know yet if scrubbing the brain clear of these bad proteins like alpha-synuclein is going to have a symptomatic benefit, slowing disease progression benefit, or another benefit. So we've got to be patient on that. On the horizon, we also have optogenetics, which we can shine lights. We do this in animals, not in humans, and it combines genetics, engineering, optics, and light-sensitive molecules, and we can achieve precise millisecond control of neural systems. It's really cool and has helped us to change and to modify and to develop new drug and stimulation-based therapies. We also have DREADs, designer receptors that are exclusively activated by designer drugs. This is one of the ones for cancer. I think we're going to see more DREADs. We're seeing it now in the research laboratory be employed in Parkinson's disease. And we need to develop a biomarker. And why is this so important, and what's a biomarker? Well, you can use some sort of marker. It can be blood, it can be imaging, it can be spit, it can be skin cells. I mean, whatever you think your marker is can be used either to diagnose a disease, and we have less of a need to be able to do that in Parkinson's disease. Where we have a huge need, folks, is we have to be able to develop a biomarker to track disease progression. If we can develop a biomarker to track disease progression, like this imaging biomarker developed by David Valancourt at the University of Florida, if these types of biomarkers will work, we can decrease the number of patients needed for a Parkinson new clinical drug or other device study from thousands to hundreds or less. And so developing biomarkers is really important. So thank you for the invitation to speak to you. This is a number of the books that I've written in the past. I do have a author blog website. Some people follow me on the blog or on Twitter or on Facebook, but we also have a book coming out here that's stuck in the warehouses with Robert Rose Publishing. This is the next in the series of 10 Secrets and 10 Breakthrough Therapies Living with Parkinson's Disease with Dr. Malati and Dr. Deeb and I, and a lot of secrets. So hopefully that one will come out once COVID lifts a bit in Canada and they can get it out of the warehouses. And so, so thanks again, and happy to take questions. And what I'm going to do now is I'm going to exit out of the screen share component here, and I'm going to flip over to the chat, and I'm going to take a few questions. Okay, so the first question comes: are we able to receive a copy of the slides? Well, I've been out on the road talking about this book for a while, so if you email me, I can put you onto the website. These slides have been out on the internet for a long time, and so so I'm sure that they're out there in the public domain somewhere. So they're not too hard to find. So that shouldn't be a problem. So thank you for the question from Jessica. We have a question, or actually a comment saying we're recording the webinar, but we can see if Dr. Okun is able to share the slides with us. So you should have them on the recording as well. And so happy to make a PDF and share it back to Vince and the group here. No problem with that. We have a comment about, looks like from Arshia. Arshia asks about her husband who has Parkinson for about 10 years. He's had DBS for about 8 months. And then the whole hardware was removed, and the results of the DBS were remarkable, but need to figure out what to do because no clear answers from the neurosurgeon or neurologist. So most of the time, Marcia, when you have hardware that goes into the brain and it's removed, particularly when things are going well, it's the most common reason for removal is infection. And so I'm going to guess that there was possibly some infectious issue that was going on here. Usually they'll wait 6 to 8 weeks, involve an infectious disease doctor, and once they're confident the infection has cleared, then the hardware can be replaced back in. With that, it's a case-by-case basis, and oftentimes you need to troubleshoot through that. But certainly, it sounds like you don't have a clear answer from your neurologist or neurosurgeon. So certainly a second opinion could be useful. At the Parkinson's Foundation, we have at 1-800-4PD-INFO, a free helpline that people can call in and get information or figure out where a center of excellence is close to their home so they can check things out. We have a DBS troubleshooting clinic at University of Florida, so we're happy to help or review the records or try to help you in any way we can. But thank you, Arshia, for the question, and I hope things look up for you. Sandra Kosick asks us, can I address any relationship of diet to Parkinson's disease? This is super hot topic, Sandra. So this is, everybody is really interested in how the gut and the brain may be related. And there was a really interesting article by the Caltech group, by Mazmanian and colleagues. And that group was looking at turning these Parkinson's disease or these animals into Parkinson's disease animals by manipulating the microbiome and then by rescuing them and doing antibiotics and changing the microbiome, how they could actually precipitate symptoms and then treat symptoms. And that was a really, I think, important paper for the field. Tim Sampson at Emory works on this area, and now there's actually a research center of excellence at the University of Florida led by Malu Tanzi and in collaboration with Emory and Tim Sampson and Matt Lavoie and a group, and they're really interested in this. At the moment, there's sparse data to know, should we have any different diets? There's some data suggesting that maybe a Greek diet is better in neurodegenerative diseases, so Parkinson and other degenerative diseases. We don't have a ton of information on this yet, but there's been some information on there. There's some information on coffee, tea, and exercise being important, perhaps something to do with changing adenosine receptors and improving the course and the symptoms for patients. So there's always been these tantalizing hints that there's something with the diet. And there's a number of studies, if you go on to clinicaltrials.gov, where people are looking at not full ketosis. You don't want to go into full ketosis, that could cause you to pass out, but partial ketosis with ketosis drinks and different diets. And I think this is going to be a really hot area. So not a lot of data yet, but I predict within the next 3 years, you're going to see a lot more animal and human data on this. So there's a question by Lewis Friedman about intermittent fasting, slowing progression by stimulating autophagy. Really great question. Intermittent fasting is, just right in there as another thing that people are talking about. We've been a little concerned from the clinical standpoint about doing this across the patient population, about patient safety. And so this is one that that might be a little bit more dangerous to put your foot into the water without working with your doctor. And I'd probably wait for some studies on that one because you can get into some trouble. Same with going to a full ketotic diet. So I'd wait for a little bit more information. So Arshia just writes back, there wasn't clear evidence of infection. All tests were clear. And so I would just say, Arshia, we'd be happy to look at the case and Vince can give you our information. There's also an inflammatory response that some people can get in their brains to the implantation. And so we'd have to look at this to see what was going on that caused your doctors to sort of back out of this and make sure things are safe, but happy to help, Arshia. So they'll pass you my information. Gloria writes, wish med students and nurses could have attended the great presentation. Thanks, Gloria. You're gonna make me blush here on camera. And Arshia, thank you. Ellen asks about L-tyrosine helping with Parkinson's disease. Do you have any idea when Sinemet will be back? It's been off the market for about a year. Okay, so L-tyrosine, and we look at the different compounds that could metabolize into dopamine. It turns out that the straight L-tyrosine and some of these 5-HTI and other compounds you see at the drugstore, those are the ones you need to check with your doctors and pharmacists to make sure they don't have drug-drug interactions. This is where I've made a mistake. I've made many mistakes. In fact, I know less now about the practice of medicine every day than I did when I first started. I mean, you get humbled, and where I've been humbled is I used to say, oh, you take whatever supplements you want. They're probably not going to be fine, but you actually do need to look at the label on some of these and see which subtype they have and make sure your pharmacist is helping you with drug-drug interactions, because we have seen some drug-drug interactions with people that are on some of these compounds like L-tyrosine and others, and just make sure and double check those. Multivitamins and things like that, not as worrisome, but there can be drug-drug interactions, so I'd watch out for that. Sinemet, it's off patent. It's been around for a long time, and it goes on and off the market with different brands and different generics. And the best advice I can give you is just be super careful about if you're on one type of Sinemet, trying to stay with the same manufacturer if it's possible, even if it's a generic. It's about a 20% bioavailability, can be that much change when you get a generic approved. So it's not the end of the world if you can't get brand Sinemet, but you and your doctor or healthcare team or advanced practice provider need to work with you to find the right dose and the right frequency. And then if you could stick with the same manufacturer, at least, usually we can find the right solution for you. What percentage of PD patients also have Lewy body dementia? Good question. So Parkinson's disease patients, after many years of Parkinson's disease, can develop what's called Parkinson's disease dementia, or PDD. Not all patients develop that. The pathology of that is similar to Lewy body dementia. And Lewy body dementia is what develops within the first few years. You see cognitive dysfunction and hallucinations and other symptoms. And so Lewy body dementia is much less common than Parkinson's disease, but it's very similar to what you can see in a subset of patients with the development of later Parkinson's disease dementia. And there's actually an argument, a debate between the experts on whether Lewy body dementia is the same or different than longstanding Parkinson's disease with hallucinations and cognitive dysfunction. But in general, much less prevalent disease is Lewy body dementia compared to Parkinson's disease. Last question: are there any drugs to reduce the off periods in Parkinson's disease? Well, there are, and the most common is just take the medicines and take them more frequently, change the dosages, not the dosages, but change the timing. So people are always worried about, do they have the right pill, the purple pill, or the red pill, or the fuchsia pill? But the safest way to actually treat wearing off is actually to change the frequency which we give medications. When you add medicines that extend the life of dopamine, like COMT inhibitors, COMT inhibitors, or you add medicines like opicapone or entacapone, they can precipitate dyskinesia. So they might help the wearing off, but they can precipitate dyskinesia. So they're tricky to use, and you really need to work with a neurologist or a really good advanced practice provider to watch out for that. On time can be improved a little bit with things like MAOB inhibitors. And so a lot of it is really adjusting the cocktail. So what can you do to be more proactive about funding? Be charismatic, be aggressive, be an agitator. You got to get out there. We need a huge activation of the Parkinson community if we're going to increase the research funding by more than tenfold, which is really part of the message of the book, Ending Parkinson's Disease. And one of the things you can do is you can get on today and write a review on Amazon.com. Like I told you, where none of these profits are going into our pockets. The Parkinson PACT is all about trying to help Parkinson. We're going to give the money back to charity, but we got to get the word out. So talk about the Parkinson PACT as much as you can, hashtag it, teach people. We got to get active, get out there and really agitate. And it looks like Annette wants to know, is there a facility with a model of care similar to UF's in Jacksonville? I'm not sure. There are facilities all over the country with different philosophies and different models. And I always suggest you call our 1-800-4-Parkinson disease info hotline and check with the great Parkinson's disease nurses. We have 7 nurses who are the best in the business, and they can help people to locate specialists close to their home. And then a lot of us are using telemedicine. And we just wrote a piece for JAMA Neurology that the silver lining in the COVID crisis has been telemedicine. I mean, we accomplished in 10 days what took us 10 years of advocacy in trying to get telemedicine approved for neurology and for Parkinson's disease. And so it's been really great. And one of the things that I would just say to you is also look at options. Maybe some of the centers can see you at a distance for telemedicine. Maybe that'll help your travel burden, and you can get access to some of the expert care depending on where you live. So and then let's see. pros and cons of using agonists versus Sinemet for young onset Parkinson's disease. There's no right answer to that one. Agonists obviously highly associated with impulse control disorders, and more commonly in younger patients. So if you get on a dopamine agonist, there's more side effects associated with that. Sinemet is still the gold standard, and this idea of levodopa-phobia, of trying to stay off Sinemet, there's going to be some long-term benefit to doing that, has been debunked by all the experts, so shouldn't avoid it just because of that. Dopamine agonists are longer acting, but they have more side effects, and you will end up needing to have Sinemet too at some point. So it's obviously can be the cocktail between the two, and agonists aren't great in general for older folks, but that is a very, very generic look at that. We actually talk about that comparison in our next book that's stuck in Canada and Robert Rose Publishing in a warehouse somewhere, the Living with Parkinson's Disease book. We talk about that. So it looks like you just got a note from Aetna that telemedicine will be covered. Yep, all the insurance carriers are starting to come around. So you need to agitate and make sure that when COVID is gone, that we keep this game. Like I told you, we've been fighting tooth and nail, bloody battle, hand-to-hand combat to get telemedicine approved, and then in 10 days we accomplished what took us 10 years in Parkinson's. We really need to consolidate that game. So with that, I think we've answered all the questions. We're sitting at 3:58. I'm going to turn it back over to Vince, and I need to actually get on to a COVID meeting. I'm running the COVID response for all the neurology at the University of Florida, but it's been an honor and a privilege being on with you. And remember, the ending Parkinson's disease, there's no profit in it for me. All the proceeds go to charity. So love to get your feedback on it. And thanks for having me. It's been a pleasure.